Good afternoon, Dr. Rooklyn.
Good afternoon to you too, Dr. Stewart. I've been doing some searching this morning. Does it seem like there are a limited number of clinical trials for asthma biologics looking at patients younger than 12 years of age?
I wish we saw more. Treating pediatric patients is different than treating adults. Their presentation of asthma has its own challenges.
It does, and about 80% of pediatric asthma has an allergic component. We also know that some populations have higher asthma rates than others.
Very true. I really don't think we can overemphasize just how prevalent pediatric allergic asthma is.
Welcome to Dialogues Dimensionalized, expert perspectives on allergic asthma. Sponsored by Xolair, omalizumab.
Speaking of the prevalence of pediatric allergic asthma in patients 6 years of age and older, I've been thinking a lot about how important it is to identify those at risk for exacerbations with worsening asthma symptoms requiring increased inhaled or systemic corticosteroids. I recently saw a 9-year-old with severe asthma. He was on a combination of high-dose inhaled corticosteroid and long-acting beta agonist, but his symptoms were still not controlled.
So what happened?
I looked in his chart at the initial workup, where I tested for allergies, and I saw that he had tested positive for dust mites. That made me realize that this allergy was probably contributing to his exacerbations. His parents and I talked about the goals for his asthma treatment, along with their concerns about his allergies and allergen exposure.
Avoiding perennial allergens is such a challenge, but having that type of information about his specific type of asthma can really help share decision-making with parents or caregivers.
Absolutely.
So I'm guessing that the next step was to talk about adding a biologic to his treatment plan.
Yes, we spoke about starting Xolair, and of course we discussed its box warning for anaphylaxis, which can be life-threatening. I also confirmed that there were no contraindications like a severe hypersensitivity reaction to Xolair or to any of its ingredients.
That's exactly what I was thinking. You said he's 9, right? Xolair is the first biologic proven to reduce exacerbations in children ages 6 and up who have allergic asthma. It also has the most real-world physician experience in allergic asthma, since 2003 for ages 12 and older, and since 2016 for ages 6 and up. Plus, the pediatric study for Xolair included a diverse patient demographic, which can be an essential point when discussing treatment goals and concerns with parents.
That study is really interesting, and based on my patient's history, in terms of asthma severity and his lab values for total IgE level and eosinophil count, it looks like the trial included children like my patient.
Yes, and the study found that Xolair reduced the rate of exacerbations in pediatric patients 6 to 11 years by 31% at 24 weeks compared to placebo. And at the 1-year mark, Xolair reduced the rate of exacerbations even further by 43% compared to placebo. Here's a look at how the study for Xolair in pediatric patients was designed. The pediatric study was a 52-week placebo-controlled study of 628 patients aged 6 to less than 12 years with moderate to severe allergic asthma. The study evaluated Xolair as add-on therapy to inhaled corticosteroids with or without additional controller medications. The primary efficacy variable was the rate of asthma exacerbations during the initial 24-week period.
During the discussion with my patient's parents, they asked for information about potential side effects. Of course, we talked about the box warning for severe anaphylaxis and other potential adverse reactions. I shared that the most common adverse reactions in pediatric patients receiving Xolair were nasopharyngitis, headache, and pyrexia. We also reviewed the medication guide. Additionally, we talked about how Xolair clinical trials included one of the largest studies of an asthma biologic in children with more than 900 kids aged 6 to 11.
I would guess they were glad that Xolair had the data to show that it was studied in kids like him with allergic asthma.
That's right. And after that, we talked about how Xolair worked, how it could potentially help him meet his treatment goals. His parents were open to starting treatment with Xolair.
That's a really good example of how much better shared decision-making can be when we have data for specific populations.
Another specific population that I've been thinking about is women who are interested in starting families or who are of childbearing age. I'd like to see more information on biologics pregnancy registries in patients with asthma.
I do occasionally get patients who ask about that. When they do, and I'm thinking about Xolair as a treatment option, I let them know that to date, Xolair is the only biologic with a completed and published pregnancy registry study in its package insert. Of course, I always note that since it had some limitations, this registry study could not definitively establish the absence of any risk. I also let patients know that in women with poorly or moderately controlled asthma, evidence demonstrates that there is an increased risk of preeclampsia in the mother. For neonates, there is an increased risk of prematurity, low birth weight, and being small for a gestational age. The level of asthma control should be closely monitored in pregnant women and treatment adjusted as necessary to maintain optimal control.
Yes, I read that study when it came out a few years ago. It's important that additional studies are being conducted in this patient population.
It is. Recent data like these keep Xolair top of mind for me, and it's another reason I feel comfortable prescribing it in special populations, like young children.
I agree. That makes a lot of sense. Hungry?
Yes.
Let's go to lunch.
Indication: Xolair, omalizumab, is indicated for adults and pediatric patients 6 years of age and older with moderate to severe persistent asthma who have a positive skin test or in vitro reactivity to a perennial aeroallergen and whose symptoms are inadequately controlled with inhaled corticosteroids. Limitations of use: Xolair is not indicated for the relief of acute bronchospasm or status asthmaticus. Important safety information. Warning: anaphylaxis. Anaphylaxis presenting as bronchospasm, hypotension, syncope, urticaria, and/or angioedema of the throat or tongue has been reported to occur after administration of Xolair. Anaphylaxis has occurred as early as after the first dose of Xolair, but also has occurred beyond 1 year after beginning regularly administered treatment. Because of the risk of anaphylaxis, initiate Xolair therapy in a healthcare setting and closely observe patients for an appropriate period of time after Xolair administration. Healthcare providers administering Xolair should be prepared to manage anaphylaxis, which can be life-threatening. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should symptoms occur. Selection of patients for self-administration of Xolair should be based on criteria to mitigate risk from anaphylaxis. Contraindications: Xolair is contraindicated in patients with a severe hypersensitivity reaction to Xolair or to any ingredient of Xolair. Warnings and precautions. Anaphylaxis. Anaphylaxis has been reported to occur after administration of Xolair in pre-marketing clinical trials and in post-marketing spontaneous reports. In pre-marketing clinical trials in patients with asthma, anaphylaxis was reported in 3 of 3,507 0.1% patients. Anaphylaxis occurred with the first dose of Xolair in 2 patients and with the 4th dose in 1 patient. The time to onset of anaphylaxis was 90 minutes after administration in 2 patients and 2 hours after administration in 1 patient. A case control study in asthma patients showed that, among Xolair users, patients with a history of anaphylaxis to foods, medications, or other causes were at increased risk of anaphylaxis associated with Xolair compared to those with no prior history of anaphylaxis. In post-marketing spontaneous reports, the frequency of anaphylaxis attributed to Xolair use was estimated to be at least 0.2% of patients, based on an estimated exposure of about 57,300 patients from June 2003 through December 2006. Approximately 60% to 70% of anaphylaxis cases have been reported to occur within the first 3 doses of Xolair, with additional cases occurring sporadically beyond the 3rd dose. Initiate Xolair only in a healthcare setting equipped to manage anaphylaxis, which can be life-threatening. Observe patients closely for an appropriate period of time after administration of Xolair, taking into account the time to onset of anaphylaxis seen in pre-marketing clinical trials and post-marketing spontaneous reports. Inform patients of the signs and symptoms of anaphylaxis and instruct them to seek immediate medical care should signs or symptoms occur. Once Xolair therapy has been established, administration of Xolair pre-filled syringe or autoinjector outside of a healthcare setting by a patient or caregiver may be appropriate for selected patients. Patient selection, determined by the healthcare provider in consultation with the patient, should take into account the pattern of anaphylaxis events seen in pre-marketing clinical trials and post-marketing spontaneous reports, as well as individual patient risk factors, e.g., prior history of anaphylaxis, ability to recognize signs and symptoms of anaphylaxis, and ability to perform subcutaneous injections with Xolair pre-filled syringe or autoinjector with proper technique according to the prescribed dosing regimen and instructions for use. Discontinue Xolair in patients who experience a severe hypersensitivity reaction. Malignancy. Malignant neoplasms were observed in 20 of 4,127, 0.5%, Xolair-treated patients, compared with 5 of 2,236, 0.2% control patients, in clinical studies of adults and adolescents greater than or equal to 12 years of age with asthma and other allergic disorders. The observed malignancies in Xolair-treated patients were a variety of types, with breast, non-melanoma skin, prostate, melanoma, and parotid occurring more than once, and 5 other types occurring once each. The majority of patients were observed for less than 1 year. The impact of longer exposure to Xolair or use in patients at higher risk for malignancy, e.g. elderly, current smokers, is not known. A subsequent 5-year observational study of 5,007 Xolair-treated and 2,829 non-Xolair-treated adolescent and adult patients with moderate to severe persistent asthma and a positive skin test reaction or in vitro reactivity to a perennial aeroallergen, found that the incidence rates of primary malignancies per 1,000 patient years were similar in both groups, 12.3 versus 13.0 respectively. Study limitations, which include the observational study design, the bias introduced by allowing enrollment of patients previously exposed to Xolair, 88%, enrollment of patients, 56%, while a history of cancer or a pre-malignant condition were study exclusion criteria, and the high study discontinuation rate, 44%, preclude definitively ruling out a malignancy risk with Xolair. Acute asthma symptoms and deteriorating disease. Xolair has not been shown to alleviate asthma exacerbations acutely. Do not use Xolair to treat acute bronchospasm or status asthmaticus. Patients should seek medical advice if their asthma remains uncontrolled or worsens after initiation of treatment with Xolair. Corticosteroid reduction. Do not discontinue systemic or inhaled corticosteroids abruptly upon initiation of Xolair therapy for asthma. Decrease corticosteroids gradually under the direct supervision of a physician. Eosinophilic conditions. In rare cases, patients with asthma on therapy with Xolair may present with serious systemic eosinophilia, sometimes presenting with clinical features of vasculitis consistent with Churg-Strauss syndrome. These events usually, but not always, have been associated with the reduction of oral corticosteroid therapy. Physicians should be alert to eosinophilia, vasculitic rash, worsening pulmonary symptoms, cardiac complications, and/or neuropathy presenting in their patients. A causal association between Xolair and these underlying conditions has not been established. Fever, arthralgia, and rash. In post-approval use, some patients have experienced a constellation of signs and symptoms, including arthritis/arthralgia, rash, fever, and lymphadenopathy, with an onset 1 to 5 days after the first or subsequent injections of Xolair. These signs and symptoms have recurred after additional doses in some patients. Physicians should stop Xolair if a patient develops this constellation of signs and symptoms. Parasitic Helminth infection. Monitor patients at high risk of GeoHelminth infection while on Xolair therapy. Insufficient data are available to determine the length of monitoring required for GeoHelminth infections after stopping Xolair treatment. Laboratory tests. Due to formation of Xolair IgE complexes, serum total IgE levels increase following administration of Xolair and may remain elevated for up to 1 year following discontinuation of Xolair. Do not use serum total IgE levels obtained less than 1 year following discontinuation to reassess the dosing regimen for asthma patients, because these levels may not reflect steady-state free IgE levels. Potential medication error related to emergency treatment of anaphylaxis. Xolair should not be used for the emergency treatment of allergic reactions, including anaphylaxis. In studies to simulate use, some patients and caregivers did not understand that Xolair is not intended for the emergency treatment of allergic reactions, including anaphylaxis. The safety and effectiveness of Xolair for emergency treatment of allergic reactions, including anaphylaxis, have not been established. Instruct patients that Xolair is for maintenance use to reduce allergic reactions, including anaphylaxis, while avoiding food allergens. Adverse reactions. Asthma. In patients greater than or equal to 12 years of age, the most common adverse reactions, greater than or equal to 1% more frequent in Xolair-treated patients, were arthralgia, 8%, pain, general, 7%, leg pain, 4%, fatigue, 3%, dizziness, 3%, fracture, 2%, arm pain, 2%, pruritus, 2%, dermatitis, 2%, and earache, 2%. In pediatric patients 6 to less than 12 years of age, the most commonly observed adverse reactions, greater than or equal to 3% more frequent in Xolair-treated pediatric patients, were nasopharyngitis, headache, pyrexia, upper abdominal pain, pharyngitis streptococcal, otitis media, viral gastroenteritis, arthropod bite, and epistaxis. Injection site reactions. In adults and adolescents with asthma, injection site reactions of any severity occurred at a rate of 45% in Xolair-treated patients, compared with 43% in placebo-treated patients. Severe injection site reactions occurred more frequently in Xolair-treated patients compared with patients in the placebo group, 12% versus 9% respectively. The types of injection site reactions in asthma studies included bruising, redness, warmth, burning, stinging, itching, hive formation, pain, indurations, mass, and inflammation. Injection site reactions in healthy adults. In an open-label trial in healthy adults, in which the 300 milligram 2 milliliter autoinjector was compared to the 300 milligram 2 milliliter prefilled syringe, injection site reactions, e.g. induration, pain, erythema, hemorrhage, swelling, discomfort, bruising, hypoesthesia, edema, pruritus, were observed in 24%, 16 out of 66 subjects treated with the autoinjector, compared with 14%, 9 out of 64 subjects treated with the prefilled syringe. Cardiovascular and cerebrovascular events from clinical studies in patients with asthma. A 5-year observational study was conducted in 5,007 Xolair-treated and 2,829 non-Xolair-treated patients, greater than or equal to 12 years of age, with moderate to severe persistent asthma and a positive skin test reaction to a perennial aeroallergen, to evaluate the long-term safety of Xolair, including the risk of malignancy. Similar percentages of patients in both cohorts were current 5% or former smokers 29%. Patients had a mean age of 45 years and were followed for a mean of 3.7 years. More Xolair-treated patients were diagnosed with severe asthma, 50%, compared to the non-Xolair-treated patients, 23%. A higher incidence rate per 1,000 patient years of overall cardiovascular and cerebrovascular serious adverse events, SAEs, was observed in Xolair-treated patients, 13.4, compared to non-Xolair-treated patients, 8.1. Increases in rates were observed for transient ischemic attack, 0.7 versus 0.1, myocardial infarction, 2.1 versus 0.8, pulmonary hypertension, 0.5 versus 0, pulmonary embolism/venous thrombosis, 3.2 versus 1.5, and unstable angina, 2.2 versus 1.4. While the rates observed for ischemic stroke and cardiovascular death were similar among both study cohorts. The results suggest a potential increased risk of serious cardiovascular and cerebrovascular events in patients treated with Xolair. However, the observational study design, the inclusion of patients previously exposed to Xolair, 88% for a mean of 8 months, baseline imbalances in cardiovascular risk factors between the treatment groups, an inability to adjust for unmeasured risk factors, and the high study discontinuation rate, 44%, limit the ability to quantify the magnitude of the risk. Pregnancy. Data with Xolair use in pregnant women are insufficient to inform on drug-associated risk. You may report side effects to the FDA at 800-FDA-1088 or www.fda.gov/medwatch. You may also report side effects to Genentech at 888-835-2555 or Novartis Pharmaceuticals Corporation at 888-669-6682. Please see important safety information throughout and accompanying full prescribing information, including boxed warning and medication guide.